afternoon, everybody. Thank you for joining Maine Health Management Coalition's Lunch and Learn How to Achieve Cost Savings and Patient Satisfaction Through Clinical Best Practices. My name is Marie Stuckey, and I'm the Member Relations Specialist here at the Coalition. We'd like to welcome both Maine Health Management Coalition members and guests, and thank Dr. Cox-Chapman so much for presenting today. We will be having all registered attendees muted to avoid distractions, but if you have questions that you think of as we're going along, please just add them to the chat box and we will address them at the end of the presentation. I'm going to begin with just a very short introduction about the coalition so that our members, our guests rather, can know a little bit more about us. So the Maine Health Management Coalition is a purchaser-led partnership among multiple stakeholders working collaboratively to improve health and maximize the value of healthcare services for the employees and dependents of coalition members and all Maine residents. We are made up of over 60 members comprised of consumer groups, purchasers, health plans and brokers and consultants, providers, and affiliate members. We have 4 basic initiatives to carry out our mission that's supported by our data department and the all-payer claims database in the state of Maine. The first initiative is transparency and public reporting, where we publicly report outcomes, safety, and patient experience and cost ratings on our consumer website, Get Better Maine. Secondly, we have consumer engagement, and by engaging employees and communities in their role in system and care improvement, including personal responsibility for health, choosing quality, and appropriate utilization of services. Our benefit design initiatives identify key patient and provider benefit and reimbursement incentives, such as value-based insurance design, that rewards the use of coordinated, appropriate, high-quality, patient-centered care. And finally, our payment reform initiatives explore alternative payment arrangements with providers, hospitals, and systems that align with the coalition's goals for high quality at a reasonable cost that's patient-centered. Just so you're aware, we are already taking registration for next month's webcast, which will cover our value-based insurance design initiative. That will take place on March 18th. If you need a registration link, you can certainly email myself. My email will be at the end of this presentation. And then in April, we'll be covering mental health in the workplace. Some of our webcasts do offer some continuing education credits. So some of the ways our members are involved, or you can get involved yourself, is through our work groups and committees, roundtables. You can come to our symposium, which is going to take place this fall. We have a wellness newsletter that we distribute. We offer training in value-based insurance design, our webcasts, of course. We also train policymakers on evidence-based medical policy. Have programs such as a CEO Champions Wellness program, and we offer our members discounts at national conferences. This is just a slide showing you our current membership, but you can certainly see this on our website as well. And if you are interested in supporting increased quality of healthcare and reduced cost, feel free to join us as a member. You can contact me at the phone number or email provided on that screen right there. So now I would like to present Dr. James Cox-Chapman to present today. He's the Senior Vice President and Chief Medical Officer at ProHealth Physicians. He's board certified in internal medicine and geriatrics. In 1997, after 13 years in medical practice, Dr. Cox-Chapman with 2 colleagues, founded ProHealth Physicians. He has served as Chief Medical Officer of ProHealth since the inception of the organization. As Chief Medical Officer, Dr. Cox-Chapman launched disease management programs in diabetes, asthma, and depression. He's responsible for initiating ProHealth's risk management program, and in addition to his leadership duties, Dr. Cox-Chapman practices clinical medicine 1 day per week in the Farmington office. He is a practicing internist, board certified in internal medicine and geriatrics. Dr. Cox-Chapman earned his medical degree from Temple University and his bachelor's degree from Williams College. He lives with his wife and 2 children in Hartford, Connecticut. And we will now turn over the presentation to Dr. James Cox-Chapman.
Hello, everyone. Just making sure that we have control over to the presentation and the slides. And I'll be right with you. So thank you very much for that nice introduction. I'd like to offer another picture other than the one with the bow tie, because I think that this would be more apropos for everybody. This is a picture of Casco Bay, looking out from a porch on Chebeague Island. And I would have to say to all of you who live in the geography of the Portland and the Maine area, you live in a wonderful part of the world. My wife and I try to spend as much time up there in the summer as possible, and I'm just offering this picture as a little bit of a respite from the snow that I know you're dealing with in Maine, because we're even having it here in Connecticut. As satisfying as my thoughts that go to time up in Maine is also the fact, the part of my career that I've spent with our risk management program here at ProHealth. And I'll tell you, this has been a surprise to me as a physician. I was asked by our CEO to take over the risk management program about 10 years ago. And like you, my initial reaction was probably one of, risk management? Do I really want to get involved in that? Tell me why this is a good place to take my career. And I can actually tell you that as we've gotten into this program, developed it, and implemented it within our practice, it's been one of the most satisfying pieces of work that we've done around the medical group. And I think I share that certainly as the leader of it, but I know our doctors do because they all participate and they rate the program very highly. And often in meetings when they say, gee, we need a clinical program, and it really should be like risk management, and they kind of rattle off all the positive aspects of it. I think the other reason it's been so satisfying is that it really applies to our entire breadth of our practice, and unlike population health and some of the new payer models, we're not carving up patients by payer population, but we're really dealing with the entirety of the medical practice and how we can plug gaps, improve quality, and improve patient experience. So just a little bit about, here's a sort of forecast of what we'll talk about today. We'll just have a very brief introduction to ProHealth, and then we'll talk about how we got involved and recognized the need to have a more focused risk management program, our experience, and the impact that we've been able to generate. Down here in Connecticut, we've traveled a very similar journey to what I understand all of you have up in the Maine area. And we are, at this point, the largest physician-owned delivery system. So this means, and I really think it's important that you understand what one of our distinctions is. We certainly are physician-owned, but we have been professionally managed along with in a teamwork kind of structure with our business team. And we really have achieved a lot of what we've achieved through this mutual coaching relationship about the business realities of healthcare delivery these days and the realities and everyday aspect of taking care of patients, something which we as physicians and APRNs and PAs are very familiar with. The business people might not be, but we're also need coaching and schooling on how to organize ourselves well for the advantage of our organization and for the patients. You can see that we've got, we're taking care of 10% of the population of Connecticut, and we have about 350 providers, I'd say 95% of which are primary care at this point. I'm just waiting here, getting direction on the running the presentation. So that's our history. We, like all of you, have been able to first go through the drill of showing some differential in contracting and in pay for performance. We then, in 2010, adopted a common EHR platform. We're on the Allscripts Enterprise system. 6 months later, we were certifying all of our primary care practices, basically all our practices, as level 3 NCQA patient-centered medical home. Meaningful use followed that, then a application to become an ACO with about 30,000 members, and then a recertification for PCMH. So like you, all of us are tired. There's a lot of work in healthcare, and it's also one of the most exciting periods that we have ever experienced. So I'm having trouble advancing this slide. There we go. So our path to proactive risk management really started about 10 years ago when we had a carrier that was that we adopted and the exception of our group in 1997. That carrier priced itself very attractively, did absolutely nothing to help us manage our patients, and we really didn't distinguish, we didn't focus on it, didn't distinguish ourselves in terms of putting any effort into this. We got a surprise about 5 years later when the carrier got downgraded in its best rating, and a year after that was out of business because they'd underpriced their business and really not done anything to manage it. We left the carrier before that happened, but we're faced with a situation where really the reality of our performance was that this carrier had spent way more in case settlement than it had garnered in our premiums. And so we were looking at the possibility of a 500% increase in our malpractice premiums at that time. That was the threat, and that was certainly got our attention to focus on things. Like most people, we blamed someone else initially, marched on the Capitol in our white coats, and thought that the problem was that the system needed reform and you needed caps against damages in Connecticut. That proved to be actually very unsuccessful, still hasn't happened in Connecticut. Connecticut has the unique situation of having a very powerful plaintiffs bar who have a lot of influence in the legislature. At the same time, patient satisfaction and attention to patient satisfaction was not yet part of our culture. We weren't doing any measurement along those lines, and we saw a clear need for decisive action, and we looked inwardly as opposed to outwardly. So the idea was we needed to control our own risk, know our own risk, and manage our own risk, and then we could pursue other ways of organizing ourselves, possibly a captive insurance company or something like that. So we created a risk management committee that included prominent leadership in the group, and by that I mean the CMO was part of it, CFO, our director of practice operations, and also several defense lawyers. We had the opportunity in Connecticut to be associated with a small company called MRM, Medical Risk Management. It now calls itself the MRM Group, and they were setting themselves up to help organizations, either hospital organizations or physicians organizations, manage risk management. What they also had on one of their other arms was a brokerage capability. So really, one of the ways they were going to provide value to us through their brokerage activities was to help us manage our risk. So the program that we developed was in partnership with them, and it's part of the rigor that they brought to us, and we brought the leadership within house is responsible for some of the results. So the first issue was to identify what the key issues were. we needed to perform baseline assessments and find out really what was behind some of these cases that were being settled against us. And one of the major things we analyzed was the reasons for the cases, and it was true then, it's still true now. The major reason for primary care, at any rate, being involved in any of these malpractice cases is failure to diagnose, failure to recognize things, failure to diagnose, failure to act on diagnostic elements that can be found there in the chart. So we created an action plan once we figured out what the main cause of our cases. I think 65 to 75% were from failure to diagnose. I think the next biggest one, or the next biggest two, were errors, and the other one was medication errors. But by far and away, failure to diagnose was the most predominant. We started first to look at what we needed to do to get the physician, our provider's attention, and we actually developed a risk management education program. I call it Risk Management 101. We put them through that first year 5 series of interactions and lectures. Many of them, a couple of them were in a modular way where they could look at them at home, but there were 2 in-person meetings, one that kind of presented the problem and sort of created the urgency for action. And the second one was actually, and I'll talk about it in a minute, risk management around cases where we would have a lively discussion. We also needed to develop an incentive program, and I think this is an interesting kind of thing that, or process we all went through. Our initial inclination was to single out the people who had multiple cases or who might have had large settlements and kind of focus on them. What we realized was that probably wasn't going to get us anywhere, because whatever corrective action we might have in terms of premium charge and anything like that to these outliers really wasn't going to sustain the program or provide any value. So what we did was develop a program, and the criteria for being successful in the program was completion of the program on an annual basis. The incentive for providers was that were we successful in generating savings with this risk management program, i.e. we took in more premium, which we were taking in from the doctors, then we expended out in cases in a given year, then the physicians then everybody who contributed that program premium would get a share of the savings. The only way that you could be eligible for a share of the savings was to complete the requirements of the program on an annual basis. We had one other threat, I guess, as part of the incentive, which is that anyone who didn't complete the program and there was a case settled during that year for that provider, they would be responsible for the first $10,000 of expense around settling that case. We've never had to pull that trigger. We remind the providers of it, from time to time, but it's not part of the driving factor. The driving factor is the opportunity of sharing in any of the savings that we do create. So those were the kind of the rewards for being part of the program. So if what we do on an annual basis is we develop annual themes, and some examples of those are one year we'll focus on documentation. The next year we might have education around and cases around the difficult patient. This year our theme is about co-managing patients with other providers. When right after we implemented EHR, it was the risk management implications of moving to an EHR platform. And the program is really 3 components, important components. One is along the theme, we would have an annual, what we call a risk management module. I think we're calling them spotlights now. There's been some rebranding. But anyway, risk management module, it's about an hour's module facilitated by both the defense lawyers and some leaders within ProHealth about various subjects. And you need to take that model at your leisure and then take a post-test. That's one criteria that needs to be completed by a certain date. The other one, which has been probably the mainstay of our program, is the attendance at risk management rounds. In this case, these are in-person meetings, but they can be done on a web format. But anyway, in our case, it's in-person meetings, and you must attend and participate in the discussion about various cases. The cases are these are actual malpractice cases from the library of the defense firm. It's around the themes that we're interested in that particular year. And there's a physician leader goes through the sort of medical aspects of the case, and then there's a lawyer there to comment on what happened, the settlement, what the allegations were, and things like that. And part of what we're doing, because we as physicians would have no knowledge of this, the defense lawyers are showing what our actions look like when we're in court. And none of us, hopefully, have had much experience with that. Although I will say the other thing we did learn was that the chance of being involved in a lawsuit is about a 5% per year chance. So if you're in practice 20 years, there's a possibility that you will be involved in a lawsuit. And again, it's some people go a whole career without them, and some have several. But the kind of statistical possibility is 5% per year. So those risk management rounds cases are well attended. Obviously, I referred to the incentive program around that. The participation is high, and the ratings year after year are 90, 95% acceptance. I'll show you some of those results, and they're often referred to as being valuable. One of the other things, and I'll allude to this at the end, is it's resulted in the empowerment of our physicians in the face of a system that they don't really understand and have felt powerless about. But I'll talk about that in a minute. The next third part of the component is an audit, and it's an audit around important themes. And for the past 5 years, we've really been auditing around, and I have some data to show you, around colon cancer screening and the carrying out of those orders or the clear documentation in the case of patient refusal. The other one has been around the treatment of pediatric patients for the treatment of depression. And the last one, which again is a constant one that we're auditing, is the recording of patient interactions when you're on call. Embarrassingly, when we started out, 31% of our providers were not documenting any inpatient interactions when they were on call. Obviously, the numbers now have improved remarkably. If you don't attend risk management rounds, or don't see the module, or don't pass the audit, you don't pass for the year. So it gets good attention. So our experience was that this was painful to start. Lots of feedback from our doctors that why was this being foisted? Why is this the responsibility of the provider? What about the patients? Where was patient responsibility? Some kind of pushing back at the idea that if you think enough to order something for a patient, important procedure, let's say colonoscopy or a stress test or something like that, and you don't have a method of ensuring that that got taken, actually happened, then you're at some exposure, because if you thought it was clinically important enough to order, where is your mechanism to make sure that this happened? So you can imagine this sparked a lot of kind of confrontation and again, some of it being bewilderment about the process, pushback about documentation and the demands of documentation and the demands of possibly defensive medicine. Our response to that always is, we want you to do what's clinically right for the patient, and we want you to share your thinking about why, what you were thinking as you were going through that. And the importance of which is that the chart is the only contemporary or contemporaneous record of what went on in the interaction. So often when these cases come to light, they're possibly 3 to 4 years after the incident. Memory gets fuzzy, or it gets it's altered by maybe what you wish had happened or thought would happen. I'm just saying this. I think this is human nature, and so you often end up with a family that's saying one thing, or successors of a patient are saying one thing, a provider who's saying something else, and the only document that was kind of there from the time when it happened is the chart. So we stress that importance, and the importance of clear documentation and sharing what you're thinking. Or another example, when you've got that patient with a small pulmonary nodule, and the recommendation is get a series of CAT scans to ascertain there's no change in the nodule. Obviously, we all know, looking for the possibility of lung cancer. That thinking ought to be shared with the patient, just saying, look, this is what we're worried about. This is why it's important to keep getting these, and there ought to be a way to track that those things are actually happening. Some of that's easier with the electronic system than it was with paper, but the electronic system still can be confounding. So what's our experience been? I talked about some of the attendance figures for risk management rounds. Completion of the program. I think in a given year with 300, 350 people, we only have 2 or 3 people that don't complete the program. So the attendance and the completion of the program has been very high. In 2011, when we polled people, they said, this is valuable. We think it should be held every year, because we wondered, well, maybe we could back off and just do it every other year. Nope, we wanted it every year. The physicians wanted to extend that to their staff, so we now run a program with the office managers and actually have a way of getting out to the offices and actually interacting with the whole whole office. Our financial, and I'll show you some of our data about our claims. The number, as we've grown the group, the actual number of claims has decreased, or on a per physician basis, there's been a marked decrease. I'm sorry, I hope I said decrease on that. Claims have decreased. Along with that has come a decrease in our premiums, and I have some slides to show you on that. And we've developed a way to kind of respond to changes and to threats. One of the ways that we do this is we ask the providers to submit to us any incidents where it crosses their mind that there was an unexpected clinical event, and it's possible that someone could interpret that and end up as a malpractice case, or any just unexpected clinical events. And I'd say we get, I'm not sure the whole number, but many incidences are reported. We go over them in the risk management committee. A small, very small fraction of them ever turn into cases, but it just is that mindset that we have people in. There probably is an impact on patient satisfaction. I'll talk about that at the end. Although if you looked at our patient satisfaction scores, that's not a strong point in our group, so the kind of one-to-one correlation isn't necessarily there. But I also think that this is an outpatient proxy for patient safety. Patient safety is a much more developed discipline within the hospitals, but we can show you, and I will offer to send to all of you a write-up of kind of a case study that's probably 2 or 3 years old now, that appeared in the Connecticut Medical Journal about the success of this program. So here you can see on this next slide, here's our claim frequency per physician. We've had an 82% reduction since the inception of the program in 2003. And this just provides a very powerful thing for us. And as all of you in your travels, I'm sure, interact with people who are not not necessarily part of healthcare, and they'll raise the specter of malpractice and what a burden that must be to you. And yes, it is a threat, and it is a part of doing our work, which is significant. On the other hand, you can see that our physicians can claim some mastery and some success in this area with an 82% reduction in claim frequency per physician. In addition, claim severity has gone down. Connecticut does have the unique distinction of having very high severity claims. Severity is the amount that claims settle for. They're typically settle much higher in court than they do outside of court. One thing we learned, well, I'll just divert on this for a minute. When a situation comes in and a case is being assessed, both the plaintiff's attorney and particularly the defense attorney, they kind of rate the claim, or the situation about how defensible it is. And if a defense attorney rates a claim as, oh, I think I only have maybe a 25% chance of really prevailing on the defense, they're not going to be as vigorous at being able to withstand, a high valuation for that or a high settlement for that case. They're going to be less apt to take it to court and take it to, go to the mat to defend it, and they're going to end up possibly settling for a higher amount than they really were comfortable with. If the documentation is tight, if the physician or APRN is credible witness, et cetera, and they think their sense of defending the case is very high, then they will ratchet up all their effort. You have to remember that the plaintiff's attorney is paying for every single maneuver that they do with these cases, and they're constantly assessing cases on how much is it going to take for me to defend, to prosecute this. What do I need to spend? How many expert witnesses, et cetera, et cetera. So that's just a way of giving you some insight. The other thing I'll say is we read about all these settlements in court. The vast majority of them, I'd say 80, 85%, get settled prior and never make it to court. So that's claim severity and amount. You can see that our malpractice premiums have reduced by about 70%. So starting out initially at around $18,000 and ending up at about $6,000 per physician. Again, we're very proud of this, and that differential, because we collected money in all of those years, and we came in at about 50%, spending 50% of what we collected, and that 50% has gone back to our physicians over the past 2 to 3 years. Past 7 years. There's about a 3.5-year delay between when we collect the money and when we can give it back, when it's safe to give it back, and that's so that you need to educate yourselves, about that. But that's been, I think we've distributed at least $2 million back to providers over the course of our program. So what about responding to threats? And I'm giving you an example here with colorectal screening. And this was identified as a problem area. And we had a pretty good process on paper before we went to our electronic health system. And you can see on this slide here that in terms of screening during health maintenance visits, that's recognizing that the screening might have to happen, putting in an order, and then following through to make sure the order either got completed or if the patient didn't go, refused, or whatever, that was well documented in the chart, and at least 2 outreaches were made to the patients, one of which has to prove got there. That's sort of what we're measuring. And you can see we were doing pretty well in the paper world before we switched to the electronic medical record. We did it over the course of 2010, but these results are from our paper system in 2009, and you can see everyone did very well in this part of the audit. Not true when we next went in and audited after the implementation of the EHR. So why was this? Possibly there's just, and you've been through this, so much attention paid to learning the EHR and just so much energy diverted toward all sorts of things away from this particular aspect. And some of it to the confusion inherent in these electronic records, because there are multiple ways that you can do things. Now, I'm not saying that we introduced the electronic record and let everyone configure it themselves and have all their own kind of configuration. We actually trotted out a pretty tight model. But that being said, there are many, many ways to document an EHR and electronic record, some of which we were picking up in our data, some of which we were not. And if you're picking up data, there's really one or two places you can look. You can't be looking in multiple places. So were we able to respond to this? We did have immediate exposure because of the audit, and we were able to react and team up a task force dedicated to educating people and making sure that that they were using the system correctly. You can see here with our with the next slide, our results have improved, but we're not yet at that 99% level. Again, I think there's just some inherent confusion about what needs to be done, how it needs to be documented, so we can pick up the data. And I do think that's an important way to be able to figure out changes and then react to them and adjust. So what's the impact been? And this is where I'm finishing up, and we're going to open up for questions. There's no question there's been improved patient communication. I gave you some of those examples about if you're worried about ruling out cancer, you need to communicate that with patients. There's no question that we've worked on follow-up to make sure that what we order and what we recommend actually gets carried out, or the patient is we're clear on that the patient has refused or is reluctant to do that and is documented in a way. We think there's been an improvement of the care, and we get satisfaction from our patients about the care that's being delivered for ProHealth. I think this is dovetailed with our focus on quality measures and just again that same meticulous process. Was it done? What's the next step? And was it documented? And I think the other, and you can see, and I've shared with you the data about number of and severity of incidents and this proxy for outpatient safety. I mentioned a little bit, but I just want to finish. There's also been a marked empowerment in provider confidence because they understand what some of the aspects of this very kind of convoluted, difficult to understand malpractice situation. They understand what's required of them to be able to have proof that the right thing was being done and some of the documentation aspects, and have given them confidence in an area that really primarily incited fear and maybe just kind of the first instinct would be to bury your head in the sand. So we think we've helped with that. We still have work to do. There's no question that we need to be clearer when we're working with subspecialists about who's taking care of what, and clarify that way, because that's where often some of the problems are, and there are other things that will come up. The plaintiffs' bar also in Connecticut is always looking for new ways that they can trip us up, and catch us unaware and vulnerable. So I'll stop with that. It's been a pleasure to talk to you today. It's been a pleasure for me to get closer to Maine with that first picture that I shared, and I look forward, to revisiting your part of the world as soon as we possibly can. And I'm very proud of, and I hear just report after good report about the work that you've been able to accomplish for your patients up in Maine. So we'll stop that and take questions and turn it over to the operators here about how that happens.
Thank you so much, Dr. Cox-Chapman. We appreciate that great content, and just want to let people know that this was recorded, so if they would like to share it with anybody else or know somebody who missed it, it will be on our website, the Maine Health Management Coalition website, under Member Resources, Archived Webinars and Presentations. And I do have a few questions that have come through for you, and we'll remind those who may be looking for it, if they have questions, to just type it into the chat box, and I will include those as well. One question we have here is, what was the most difficult part of implementing a program like this?
That's a good question. I think it was probably getting the provider's attention to put it on their plate and to embrace it as part of what they do, and in sort of attitude of how they, that's an important factor in how they're managing patients and thinking about patients. That was sort of tempered by also, we're not encouraging people to think of every person as a potential suit and go operate defensively. I think that's part of it. What really lubricated this whole thing was the intense satisfaction that people got out of the risk management rounds process and attending these meetings. It had lots of credibility, and I think it helped that we had the kind of financial aspect. This is a private practice organization, or one big private practice, so the financial benefits also were helpful. I'm not sure I answered that correctly, or anyway, that's my first pass at it.
Okay, well, I guess another similar question that kind of builds on that is if there were any performance metrics used to motivate your physicians.
The major performance metric was completion of the annual program, and that's attending the rounds, seeing the module, and passing the audit. And I believe that whole activity, and that's probably 3 to 4 hours a year of this kind of work, but that whole activity had sort of a halo effect of just kind of saying, all right, I got to think about this in some situations when I'm dealing with people.
All right. We also have somebody wondering how you went about identifying the areas in need of education.
The areas of education?
Right.
Well, the first big move on that was to find out why the cases were happening, and that would be around identifying that failure to diagnose was the #1 issue for primary care. And then we looked at the kind of, and those fall into heart disease and cancer largely, and we kind of moved the education, the initial education around that. The other themes have come up actually as the programs moved along and medicine has changed. The electronic medical record and the pitfalls of using the record. One example, using the copy forward function in an EHR and having some discussion about a patient just kind of looked the same visit after visit, and that kind of thing was is one thing. So the kind of the various elements of the EHR and the fact that for a good forensic look, everything you do in that device, in that software can be detected. So those were one of the themes, and now we're moving into more as the as the coverage limits have decreased. It's roughly around 1 million or 2 here. The plaintiffs bar are hooking in other providers, so the interaction between us and other providers and really differentiating who's going to take care of what is a focus. So some of that's evolved as medicine's changed.
Thank you. Okay, we do have another question here. Can you describe the process you used to agree upon what ends up being defined or standardized on as the best practices to use?
I guess I'll give the example, 2 examples. One around the on-call documentation process. Within our, we recommended one system, which is that these on-call, you document in the EHR on an on-call note, and that has certain characteristics. the date of the call, the time of the call, the time at which you got back, you know, within 30 minutes and things like that. So there were standards around that practice. We had some providers who cover with groups outside of ProHealth, so there had to be a sort of secondary practice, which would be to document in writing the interaction and then make sure that that's faxed to the provider and the outside provider and then kept in a folder. So there was some specific detail about the actual workflow and what we were looking for. In terms of colon cancer screening, there is a specific best practice about how to order a colonoscopy. We had set up safeguards in the EHR about any colonoscopy order. If it's not done in 90 days, is viewed overdue important and needs to be worked by the staff. That one, in all candor, has been difficult because, as you know, the staff are faced with lots of things to do, and the fact that they're not working that bucket, you know, something we need to pay attention to all the time. In terms of, so this is really best practice that will minimize minimize the possibility of a malpractice case, or certainly augment the defensibility. And that's more about work process and documentation than it necessarily is clinical best practice. Obviously, both of them are necessary.
Dr. Cox-Chapman, are you able to use your success as a recruitment tool?
Yes, actually, we are, because when we first got going on this and we talked to other practices interested in joining ProHealth, there were instances where those practices, if they'd been in practice, you know, 10, 15 years, whatever, not had a case, at the time, early on in our program, they would have a lower malpractice premium than we would, because, you know, we were a large group, so we were bound to have some cases, and our premiums were higher. So we had to go through probably a 6 year period where we had to kind of do a negotiation with the carrier about you know, bringing those practices in and getting a more favorable premium. About 3 years ago, because of our experience, and the experience I've shown you, we now are at the lowest or below the lowest premium offering for this carrier. Our carrier, which is the old ProMutual company now called Coveris, they're the main primary care carrier in Connecticut. So we're now rock bottom in terms of the premium. So that is not a discussion anymore with the groups, and that's been very helpful. So, and the fact that they've seen that our malpractice premiums are low and that we've got an effective program to stay that way has been helpful.
Okay, have another question here. Can you speak to the time and resources that you needed to devote to the program? Did you have any? Did you have to add any FTEs?
Within ProHealth, we did not, although that certainly could be an option for your organization. I, as Chief Medical Officer, in the early stages, I was devoting probably a third of my time, you know, or maybe 20% to 30% of my time to this. Now it's much more kind of programmatic, and I mentioned the time that the CFO and other executive leaders do. A lot of the staff work was undertaken by our relationship with the MRM group. So they would assign a person to our account. The case generation for risk management rounds and everything like that was generated by them, reviewed by us ahead of time, and then presented to the physicians. So most of, and one of the things that's distinguished them is that they've got the good ability to implement this kind of thing. And what we do is we sign a yearly contract with them for that service. You absolutely need good internal, credible leadership within the medical group, but they will provide a lot of the infrastructure for that. And of interest, and this is another thing that you need. We were able to, with our insurance company, have a CEO to CEO relationship with the insurance company, and the insurance company saw the value in this. They pay for this entire program. So this does not come out of our practice financials or our financials at our internal financials at ProHealth, other than the time that people like me and the CFO dedicate to it. But the Coveris picks up the tab for the MRM group consultation. That was actually a selling point to the doctors because they saw this additional infrastructure around, well, who's paying for this? They were not paying for it. They were enjoying the benefit of it through their hard work and the reduction in premiums. So we have not gone the route of going to an offshore carrier. That's probably a way we could save a little more money on this. We've just looked at it and we've said, we've had good success. We've got a good relationship with Coveris. They showed their willingness to adjust, and they also and we have the MRM group. So this is what we've been doing. We've focused on other areas.